I want to thank the authors for keeping on time. The next paper comes from the United Kingdom and England. Drs. Raptis, Gore, Boulos, the value of CEA and CT in early diagnosis of colorectal cancer recurrence, to be presented by Dr. Raptis.
Mr. Chairman, ladies and gentlemen, good afternoon. I would like to present our study on the value of CEA and CT in early diagnosis of colorectal cancer recurrence. We've got no affiliations to report. There's a continuous debate on the issue of follow-up. Some suggest that it may provide patient support and facilitate an audit, and others suggest that it may improve survival. The terms intensive and non-intensive follow-up have been used in the literature in numerous studies, but there's no clear definition. Non-intensive follow-up groups included 4 clinic visits, a median of 4 clinic visits, while intensive ones included a median of 14 clinic visits within a period of 5 years. Similarly, non-intensive follow-up groups included a median of 5 different investigations, as you can see in the box on the top right, and intensive groups included a median of 7 different types of investigations. The follow-up protocol of our institution is risk-adapted, and UX-A patients have 3 monthly CEAs for the first 2 years, and then 6 monthly CEAs up to year 5. Similarly, for UX-B and C patients, 3 monthly CEAs for 2 years, the additional 6 monthly CT scans for the first 2 years, and 6 monthly CEAs up to year 5. Here you can see the gender, site, as well as tumor stage distribution in our study. Approximately 1/3 of our patients had a high CEA, and the remaining 2/3 a normal CEA. Recurrence was detected in about 2/3 of the patients with a high CEA, and false negative CEA was in 22 patients with no recurrence. Group 2, the false negative CEA group, here we can see that CEA correctly excluded 136, the majority of the patients, 94%. So here we have group 1, the CEA positive recurrences, group 2, the CEA negative recurrences, high CEA and normal CEA. The diagnostic efficacy for CEA and CT combined is highly accurate. Of the 50 patients with recurrence, 12 had a secondary procedure and 38 had chemotherapy plus minus radiotherapy. Of the patients with a normal CEA recurrence, 6 patients had the secondary procedure and 2 patients received chemoradiotherapy. Of the 38 patients that had chemoradiotherapy, only 15 survived for more than 2 years with recurrence. Of the 12 patients that had a secondary procedure in the group 1, only 7 patients survived for more than 2 years with recurrence, and only 1 patient remained disease-free for more than 2 years. However, in group 2, the CEA negative recurrences, or the recurrences that were detected on CT only, shows that all 6 patients remained disease-free for more than 2 years after a secondary procedure. And those 2 patients that received chemoradiotherapy they died within 2 years with recurrence. The overall 5-year survival was 74% of all patients, 37% 5-year survival for patients with recurrence. That group includes both patients that had chemoradiotherapy and a curative resection. And here you can see that we split it down into two groups, the normal CA recurrences and the high CA recurrences. And although the numbers are small, you can see statistically significant better survival for the CA negative or the normal CA group. Although the numbers are very small, this observation has been reported in the literature by other studies. So in conclusion, the recurrence detection and survival rates are similar to those in the literature, with our follow-up protocol including fewer investigations and fewer clinic visits. And a meta-analysis that looked on randomized controlled trials that compared intensive versus non-intensive follow-ups shows that only those that included CEA and liver imaging in the form of CT scanning and ultrasound scan had the benefit in survival. A recent cost-effectiveness analysis shows that there is an absolute reduction in mortality of 9% with an incremental cost-effectiveness ratio of £3,077 for the UK. Thank you very much.